was the director of primary care for the state of Kansas for a decade. I've been in leadership roles in a number of health systems, including very fortunately being the CEO of a federally qualified health center that includes Dixon in its service area. And I was CEO of Central Ozarks Medical Center, which is headquartered in Richland, but kind of covers all those counties at the lake and south of that. And then since coming to KU School of Medicine, I've obviously provided some support to the Heartland Health Resource Center, especially early in the pandemic, really keeping us up to date and understanding what was happening when it came to telehealth and policy. And now I'm program director and for a number of programs that extend telehealth, specifically behavioral telehealth with a focus on schools and rural communities in Kansas, and in the process actually of working with some school districts in Missouri, including the Eldon district, and then South Callaway and Kennett districts, hopefully beginning this summer. We'll begin with that work with us that uses community health workers and other things to really get at how to do telehealth. On top of that, I was talking to Shelley earlier. I'm fortunate to serve as a technical assistance provider with an initiative called Come Back KC that really focuses on Kansas City as a technology hub. And I specifically work with Shelley and some others that have e-health solutions and work in the area of telehealth, and helping them build their work and their program. And then also teach for KU in the areas of like health systems and policy and finance and law. So I've done a little bit of everything, been around everything, and kind of been around a long time. I think people are sometimes surprised to figure out where I show up next. So really want to talk today when it talks about buy-in, whether it's your CEO, whether it's your board, your executive team, I've really come down to these ideas of core concepts that I think are crucial for anything to be successful for any type of project like this. And so some of you have heard me talk about this before when I talk a lot about, partnership and bringing the community in and how do you bring in disparate organizations in an initiative. But I really think, and we'll come back at the end and we'll look at these core concepts and think about how the types of questions you would ask yourself related to them as you want to make a successful telehealth program. And I can't see, Rachel, any any questions or anything. So if anything comes in on the chat, just please feel free to jump in. But also anybody else, any questions you might have, or anything you have to say, anything you have to add, you're not going to bother me. Just please feel free to speak up. So when we talk about engaging leadership, one of the things we have to think about is, well, what's going to be important to them? And when we think about the leadership, what's most important is they need to meet the needs of the community, right? Any type of organization, any type of entity that's serving the public has to, first of all, think about what does the public need? But also you have to really focus on, is this going to be financially stable? Is it going to be viable? And are the staff happy doing it? Are they all going to quit because, this is just not working for them? It's too much work. And those are the kinds of things that we'll think about today and we'll talk about today as we look at this. So really, this idea, going back to, building the ballpark in the cornfield in Iowa, if you build it, they may not come. I have, through my time, seen more and more and more programs, right? Over and over and over. I'm talking to entities and providing technical assistance, and they've tried telehealth. I worked with a federally qualified health center that tried telehealth, tried services in a school district that has 6,000 students. Should have been successful. Kids need care. Kids don't have care. But they finally, kind of pulled their program out of the school district. And it really comes down to, well, how did you make it useful? How did it meet the need? How did you understand the need? Often what I see with telehealth programs, especially when people are starting, is one of the things they'll say is, we did it and it didn't work, or people aren't coming. And then I'll find out that it wasn't there when it was needed. They had some openings and you could use a telehealth appointment wherever the openings were. Well, or I hear the staff didn't like it, they hated it. Well, how much more work was it? What kind of resources did you have in place that made it easy to do? Did you ask them to flip back and forth between telehealth and in-person and make it confusing and difficult? So it is possible. And I've seen so many programs that haven't been successful because they didn't really think about how did we engage the public? How do we engage our staff? how did we make this work? How do we make it easy? Everything that you have to do to have in-person services being successful, you have to have a complement or a component of what you're doing with telehealth that's similar. So when you're thinking about decisions on telehealth, the things I would say to think about is it something that's not available or not easily available, right? So is it something that we need to think about telehealth because we don't have it in our community, it's not accessible in our community? As an organization, obviously your CEO, your C-suite, and your board are all going to be saying, is it financially viable, right? You can't give away care. You can't give away services. You can't have a provider sit there and not be busy while you're waiting for them to maybe have a telehealth appointment. Is there community or patient support or need? Is this something people are going to use because they need it? And is it something that you're constructing in a way that it's easy for them to use, that they can access it? So how to be successful? Staff buy-in and support, right? Bring your staff on board. And additionally, bring in your public, right? Bring in your patients, find out how to make this work for them. Your clinical leadership, and we'll talk a little bit, you have to have a champion, you have to have somebody who really sees this as a need, who's really behind it, and that you're giving the capacity and the time to be successful in championing it and making it work. And then of course, the community and the patient buy-in and support. So kind of moving beyond kind of the things that a CEO would want to think about, and also that you would want to think about when you're talking to the leadership of the organization, or you're promoting adding a telehealth service, or moving into some areas of e-health or some other things, remote patient monitoring. It's so underused, it's so beneficial, and you can have such amazing outcomes just by quickly checking in with your patients. But when you think about the board, right, because every health system, almost every, has a board. There are decision makers beyond the CEO, and for-profit would be shareholders, but most of the time, or a lot of the time, when it comes to healthcare, it's a board of directors. So one of the things to think about is, what are their duties, right? So this is the basic duties of any board: strategic governance and oversight, serving the organization's stakeholders, managing the budget, setting policies, overseeing personnel, setting goals, measuring goals and achievements, right? This is what happens in a board meeting. It's what they're ultimately responsible for. But when we think about what's important to board members, right, and making a decision and signing on to something, right, because sometimes what you're selling to them is, we know how to make, being financially viable doesn't mean on day one, right? Most new systems, most new programs, most new areas, a new provider doesn't pay their own costs, right? One of the things you have to think about is, don't add services too fast, don't add new things too fast. Because if you add too many new things, you add too many new providers, because suddenly all of a sudden you can hire a bunch of doctors and you've been desperate for doctors. Remember that it takes a long time to get them enough patients, to get them active enough, especially if they're a new grad, right? There's a ramp up. You don't want to so overwhelm a new grad that they leave because they're overwhelmed. And it's going to cost you at first. So when you think about the board, it's a long-term plan, and everything that you do, you need to understand, how are we going to support this until it can pay for itself? And then on top of that, how will it not only pay for itself, but cover maybe some other needs that we have, right? Financial viability means you bring in enough money to cover all the needs, all the things that are the cost to your organization. So the board is responsible for the success of the organization, right? So boards are going to be cautious or be concerned if they see a telehealth program that they haven't understood how it's going to be financially viable, because one of the things that boards think about the most is fiduciary responsibility. Nobody wants to be the board of directors. Excuse me, my computer just came on. 1 second. Sorry about that. Nobody wants to be the board of directors that tanked the clinic, right? Nobody, they've got to understand, and boards often come back to their fiduciary responsibility, especially because they want to keep this organization. And when we talk about rurals and other underserved areas where telehealth may be one of the solutions you have to not having the providers and the other things that you need in your community, really make sure that it's clear and that you're following up and that you're providing good information, so that they understand that they're going to meet they're going to meet the needs of the community, which is their other big concern, right? They're there to represent the community, and they want healthcare in their community. They want people to have access to the things they need in their community, but also be able to really strongly show them how, yes, it takes a while to get started. Here's how we're going to cover that while we're getting started. And here's the ultimate payoff in the end, not only in the services being available to our patients and our community, but also in leading to a financially healthy organization. So kind of moving on to staff, and really wanted to talk about the three main groups in a healthcare organization before we talk a little bit about the community. So right, first that leadership team, the CEO, the CFO, the chief medical officer. Secondly, the board of directors, are kind of in the end feeling like the financial liability and long-term goals of the organization are their responsibility. But thinking about the staff, because it is important, staff wellness, staff happiness, and staff want to serve the community. They're there to serve the community. So the first question, to really think about when you're looking at engaging your staff is, will telehealth assist with a pressing need or issue that we can't meet otherwise, right? Are our patients not getting ultrasounds? Are they not going to their specialist visits? Are they not following up? Are they not able to come to appointments? Would we be able to better serve them if we could do telehealth to the local nursing home? I was really fortunate, for example, that COMC was the medical director for the local nursing home. It's just a few blocks away. So for us, we would travel around there. But you can really think about, especially one of the biggest pieces of information that comes out when you think about long-term care is the main reason that people have to leave their home community for 60, 70, 80 years, right, is long-term care is not available in their local community. So telehealth, for example, may be a way to kind of stabilize and keep long-term care by getting some of the medical supervision and some of the other things that you need that may not be available in that local community. That's just one example. So, and then how will this fit into the work environment? Telehealth has to fit the work environment. It has to not be more work. You have to build in systems that are separate, that work, that are not asking providers and staff to do, the biggest way I see systems fail or new endeavors fail is you say, I want you to do your job all day, right? See the patients in the exam room and somehow fit in these new responsibilities and this extra workload. And we're not going to build in systems. We're not going to build in staffing to make it easy for you to do so. We're not going to take something off your shoulders. So the biggest thing I see time and time again when I provide technical assistance to telehealth programs that are having struggles, that are not successful, that don't get the patients, but also where they tell me the staff hate this, right? They don't like it. They don't want us to do it. They hate it. We tried it. It didn't work. As well as the technology. Gosh, you've got to think about the technology and make sure it's technology that works well, that's going to be usable. Is that bad systems make unsuccessful telehealth programs, whether that's your technology, whether that's your internal system, whether that's how you sell it to the community. You've got to think through, how do we make this system work for everyone? So I would tell you, think about separate systems, time, staff considerations. Telehealth should make things work better, not add duties and responsibilities in addition to the existing ones. And it needs to be easy to use, easy to access for both patients and staff. So you need to figure out ways, how can we make this work for patients? One of the things we've seen with older adults and use of telehealth, and one of the reasons why there's been so much of a push for audio only, right, is especially early in the pandemic, but even continuing, those who use telehealth often have issues of access to computers and to Zoom and to everything else. But secondly, just maybe not comfortable with technology. So, we're seeing, and luckily we're retaining some of these audio only components. So think about ways that work well for the patient. Are providers and staff comfortable and familiar with offering these services to patients, right? How do you bring them on board? How do you make them feel comfortable? How do you make it work for them so that they can offer it to their patients and find ways where it may be beneficial to their patients? And have you identified where is your staff capacity to manage these additional services, especially in the beginning? It takes time, it takes effort. And then on top of that, who are your champions? Who are going to be the people that'll be kind of at the forefront and say, okay, I'll take some patients, right? I'll try this out. I'll help you figure out the bumps, the things that don't work. You got to have those people that are on board. And in my perfect world, it'd be your chief medical officer, right? Who says, I'll take some patients, right? You always want to serve by example, but also the chief medical officer has a voice in a way that other physicians may not have, or that others on your staff and your team may not have, to say, hey, this isn't working. How does this work? So kind of moving from that, the other thing I see is this idea of, okay, we had it, it was available, they didn't use it. And the thing to know is, okay, well, first of all, was it even a service that people wanted, right? Is it a service that they weren't willing to travel for, that they would use if was available locally? So pay attention to your needs assessment. Ask some of these questions about what is needed in the needs assessment. One thing I find, because I've read so many hospital needs assessments in my career, um, often you find things like cardiology and oncology coming up in the hospital needs assessment for hospitals that aren't really going to be able to bring on an oncologist, aren't going to be able to get a cardiologist on site. So you begin to say, hey, and begin to ask your public and ask your patients and say to your patients, if, this cardiologist that we're asking you to travel 45 minutes for was available for telehealth appointments, would you come? Is that a way for your routine visits? So then maybe once a year you'd travel to the lake or Springfield or to St. Louis or to Columbia. Would it work? Would you do it? Does it bring a resource that can help with the needs of the community? I'm a huge fan. I run an entire program based on school-based telehealth, right? In schools, we find kids that don't have medical care. We find kids that don't have behavioral health care, school districts that desperately need therapists and other behavioral health services, where you're probably not going to get enough of those providers into the community. And that's really what we focus on, right? Is through telehealth, getting those specialty services. One of the biggest things I do in my work is taking the behavioral health specialty services. I work in behavioral pediatrics, making them available so people aren't having to travel to Kansas City. You think Columbia is hard to get to from Missouri? Try being in Western Kansas and having to travel to Kansas City. Our campus, right? KU Health Systems campus literally goes to State Line Road in Kansas City. We're as close to Missouri as you can humanly be. And yet we ask people to travel, right? We ask people to travel on, 2-lane highways, long distances. And so so for us, it's thinking about how do we get these services? How do we support these school districts? And also how do we support those providers in those local communities, right? So filling an unmet need. And able to access these things without leaving the community. Those are the kinds of things to think about. And then trust and know why you're doing this. If you can't tell me kind of like, we desperately need this, we're not meeting this need, this is happening, you have to start from a place of saying, we really need this service, right? There has to be a demand, not only in your patients, but also, from your staff saying, I'm tired of not being able to meet my patient's needs. I'm willing to give it some time and attention and kind of go through the growing pains and the learning pains to get there. And you have to openly communicate with the community, right? How do we get this started? How do we make it happen? How can we make it work? And that's really where this idea of partnership comes in as a cornerstone of practice. Partner with your community, partner with your local organizations, partner with your patients, partner with your own staff. So that's where you get into, mutual respect, dependability, trust, and to problem solve together. There'll be problems. Starting any program has problems. Making a program successful has problems. It's, are you willing to face those and discuss those and figure them out? So just thinking about the resources as you think about your program or making it more successful, definitely, everything I do right now, we have $2.8 million a year over the next 5 years is funded by HRSA and SAMHSA. So I'm coming to you as somebody who you can start your program, you can get things going. And as a local healthcare provider, there are grants and there are not, opportunities. Office of Rural Health Policy at HRSA, tell any rural group, if you don't have an ORC grant, Office of Rural Health Policy grant, for something you want to do, because they have the rural health networks, there's so many different opportunities. You need to be really, really looking at the funding opportunities for the Office of Rural Health Policy. I've been funded, all my programs are partially SAMHSA, and then the others are for the Office for the Advancement of Telehealth. Just wrote our first ORC grant. Really excited to hopefully have a rural health network begin to be established from our work with schools and local communities. At one point I had, I think all but one of their grants, I didn't have their Black Lung grant. So I'm a big fan of, when we talk about how do you make it pay for itself long-term, well, bring together your community, write a rural health network grant to bring in the services that not only you, but the nursing home, the school, the hospital, bring in multiple stakeholders and definitely look at those rural health network grants. Office for the Advancement of Telehealth. Right now I have 2 of those grants, Evidence-Based Telehealth Network Program and Telehealth Technology Enabled Learning Program. The Bureau of Primary Healthcare focuses on FQHCs, Bureau of Health Professions, Bureau of Health Workforce, lots of different programs and things out there. SAMHSA, if you're in the behavioral health field or wanting to provide behavioral health, SAMHSA has a lot of great opportunities. Currently, March 27th, we're turning in another application to SAMHSA to continue our work there. USDA, when it comes to the backbone, has a lot of different resources that we could certainly do an entire session on, sort of the USDA and other resources to help pay for broadband and structures and technology and things that you need. Definitely make use of your associations, your primary care association, if you're an FQHC, your hospital association, rural health associations. I'm really proud of how strong Missouri's Rural Health Association is. I think it's one of the best in the country. And one of the things that I'm most impressed with is it is the most involved in terms of the number of different provider types, rural provider types, and other rural entity types that are part of the Missouri Rural Health Association, which I think is a real strength. You don't see as often rural health associations like the one in Missouri, where so many different types of organizations that focus on rural areas and not just hospitals or rural health clinics are part of that rural health association. So in Missouri, I would tell you, I go every August to the Missouri Rural Health Association meeting. I'm not even in Missouri anymore, but it's great. It's a great meeting, and they're a great group, especially if you don't fit into like a hospital association or a primary care association. And then there are technical assistance providers like Missouri Telehealth Network, like the Telehealth Resource Centers, and I apologize that I didn't put the Missouri Telehealth Network on here, which is obviously one of the great technical assistance providers in Missouri, as well as the work of Oklahoma State and Tim and others. And then, of course, the USDA is also great. USAC, if you don't know that term, you need to know it. I did in Richland, Missouri, did some really amazing work getting our broadband paid for, getting reimbursed for our broadband so that 80% was covered through federal reimbursement. So there's some real opportunities there. So I did want to talk, these are some feedback I got from Michelle Carnes, who is at the Office for the Advancement of Telehealth, and she's the Program Officer for the Telehealth Resource Centers, and Sarah Afaye, who used to be with the Office of Rural Health Policy. She's moved on now to the Bureau for Health Workforce. But just things to think about when you think about telehealth, it's always nice when people kind of reiterate, and to be honest, a lot of what I'm saying, I went out and asked them what they thought, and I'm kind of repeating what they said. Just remember, areas with the most need are often those with the least access, which is why you may consider telehealth. Make sure you're reaching out to organizations in your communities. Also, find out who else has done it. Biggest thing I can often do is help people know somebody else to talk to or somebody else to go to who's tried something similar. Start small. Don't bankrupt your organization by jumping into telehealth when you're not ready. Figure it out, see if it works, and then grow. Help bring your partners along, including your patients. Understand the readiness, right? Are they going to use telehealth? Why won't they use telehealth? What are the issues? And then with really understand your community. I can't say that enough. Know your community. Know your partners. Know the other organizations. Really understand the community, who's being served, who are the people doing it. Really use telehealth as well as other things to kind of bring everything together to understand how do we make a healthier community overall. And then leveraging funding and resources, right? Can't tell you enough to go get funds from somebody else if you can. So thinking about financial sustainability, which is often the reason why programs are ended or not started to begin with, consider grant funds. I talked about a few places to get those. Make sure you understand what's billed, how you can bill for it, and then build your financial model off that long-term for sustainability. Even if somebody's funding it, like the Office for Rural Policy, they want you to be able to show how at the end of it, it can pay for itself and continue. Think about, you may not directly bill fee for service for some of the things you do through telehealth. One of the programs I'm working with really substantially right now is use of community health workers in telehealth. And I know Missouri has had some of that as well to manage care and engage care. So think about the value-based models and payments and how that can pay for it. A lot of the work with community health workers in Kansas comes out of Missouri, in Missouri, comes out of Missouri's embrace of health homes early, Medicaid health homes, right? So that per member per month for those individuals with high needs, high cost, chronic disease, right, allowed people to hire care managers and hire community health workers to really work with those populations. And then think about how would this save money? Unfortunately, we live in a world where it has to be money for your organization. Long term, wouldn't it be great if we could show that we're saving the entire system money and somehow get someone to help us pay for the cost of it, even if I can't make it off of reimbursement and other things. Consider resources, internal. What do you have that could be used? Who do you have that could be better used? What are other community agencies and resources availability? Libraries, private spaces and libraries are a great place for telehealth. Funding, like I said, think about government grants, but also getting started. There could be funds from the community, regional, state foundations, Office of Rural Policy, Office of Advancement Telehealth, Universal Service Fund, rural development grants. We can go on and on about this, and always happy to talk about innovative ways I've seen people get things paid for and funded. So things to keep in mind. What's your model, right? There's a lot of different models. Do you want to have in-house staff, contract staff? Do you want to work with the University of Missouri? Who are you going to work with? You have to have dedicated support staff and structures, right? You wouldn't ask a doctor to check in their patient at the front desk, take their vitals and wait, and then see them in the room. So don't ask them to do that in telehealth, right? You have to assign staff, warm handoffs. Huge fan of warm handoffs, right? How are we making this so it's easy for the patient to access, right? They just click on a link. There's somebody there to greet them. There's somebody there to walk them through it, and then the provider appears in the room. But from the provider side of things, how do I make it so it's just like the doctor would do if he went into a room? And what I mean by that is, right, a physician's going to hate telehealth if they're sitting there doing all the early stuff, right, when they're busy and their productivity is what they're paid on, or what they keep their job on. Yet we ask them to do the same. So how can we make it so that the provider has, they walk into the appointment, they bring up the Zoom link or whatever it is, in a way that it's just like they walked in the room. All the stuff was done, they were checked in, they were in the room, they were ready to go, the information I need is ready to go, and I can quickly see the patient, meet their needs, and be done with the appointment, right? That's going to be a successful program. Understand how are the records going to be kept, especially if you contract with someone else for these services. Say you wanted to have a psychiatrist that would contract with you, have in place, really plan this, have procedure manuals, policies, just like any other type of healthcare activity that you would undertake that was new. Make sure you have adequate broadband capacity and IT systems and support. Understand your payer mix and what the reimbursement is. And this is a big one, right? Everybody's scared to death, and it's been really hard. We jumped to telehealth because of COVID. And then since then, nobody's wanted to make their systems permanent because they don't know what's going to happen after COVID. So we're getting to after COVID. So there are some things ending at the end of the public health emergency. Some end at the end of 2024, and some have been made permanent. And hopefully some of these things that won't end until the end of 2024 due to federal action will be considered and made permanent. But it's important to know those things. For me, the easiest place to look is Medicaid. CMS, has a zip file. It's an Excel spreadsheet. Right? You can look up. Why can't I think of the word? You won't think I work in healthcare. Like 99213. It's not an ICD. It's a. Oh, you can say Rachel. Sorry, I can't hear it.
CPT.
CPT. Thank you. Isn't that embarrassing? Sometimes you just can't think of the word, but you can look by CPT code to understand kind of what it, currently allowed by telehealth and when it's going to end, if it's going to end. So I do want to talk really briefly, and that's not the presentation today, but as we get to May, as we get to the end of the public health emergency, the two things that I think, that stuff, the billing and what ends when, we know it now, and we can look at it and you can plan your program based on it. So there are two things though that I think people have to take into account and have to remember. One is that there was enforcement discretion of HIPAA during the public health emergency. So there will no longer be this enforcement discretion from the Office of Civil Rights. So you will need to make sure that you're using a HIPAA secure and BAA covered video platform and patient communication tool. We can go into a whole discussion of what a patient communication tool is, luckily defined by CMS. And then of course, we want, obviously we have this opioid crisis, we have a drug crisis, we especially have it in rural areas. So thinking about controlled substances to patients using telemedicine. So in February, right, because there's been a waiver of some of the DEA requirements for buprenorphine and other things. So let's look at kind of what's going to change with that. So in February, the DEA did propose 2 new regulations under which practitioners can prescribe controlled medications to patients who they haven't evaluated in person, right? That's the key, being able to prescribe these things when you haven't seen them in person. So the DEA is using the CMS definition of an interactive telemedication system that does include audio-only communication for purposes of diagnosis, evaluation, or treatment of a mental health disorder to a patient in their home under certain circumstances. Whole other session we can go on that one too, but we're lucky that we have staff that can provide help on that, and we certainly hope that you'll contact us if you do have those questions. But this new DEA proposal would expand for the induction of buprenorphine via telemedicine encounter, right? So you wouldn't have to see the patient to get them on buprenorphine. And then there's a whole area of controlled substances when you haven't had a prior in-person medical evaluation, and that's for non-narcotic Schedule 3 through 5 medications only. So definitely we'll provide you more information on that, but wanted to kind of bring that up. So finally, how do you engage your patients in telehealth? Well, it comes back to how are you successful? It comes back to these initial things. So thinking about each of these areas that I think are important to partnership, whether it's with your patients or your community, when you talk about trust, does your plan take into account the needs and preferences of your patients? Preparation, how does it help them feel confident and comfortable? Collaboration, how does it meet their needs? Communication, do they understand what to do and when? Shared values and goals, does it meet their healthcare needs in a manner that fits their life and accessibility? So my biggest takeaway, and this is not flippant at all, I tried to think about what is a sentence that sums all this up. So to me, a successful telehealth program meets unmet patient and community needs while being accessible, profitable, and manageable. So, I mean, really, that's it, right? Is it accessible, both to your staff, but to your patients? Is it profitable, right? Can you afford to keep it going? Is it manageable, right? Is it something that you can do on a day-to-day basis? That's it. That's what I have. I hope that didn't seem too simple or too much, and I know I talk really fast.
You did talk fast, Robert, but it's okay. I think that was a really great presentation. I thank you for bringing that today. It brings up so many good points that we have to think about, whether we're working in an existing telehealth program or trying to move new things along. And I've got some questions, I've got some comments, I have sort of a case I want to talk about. But before I take over this conversation, I wanted to see if anyone had any questions or points of discussion from the things that Robert brought up. Please just unmute yourself and jump right in. Shelley, go ahead.
Hi, I'm always excited about telehealth and always excited when Robert presents. So I'm really encouraged by what you're talking about. I liked your takeaway point, and I think sometimes it's one-sided. People are really concerned about what's going to happen at the clinic, whether someone's going to get reimbursed, or they're leaning more toward the patient's needs. All of those are important, but there has to be such a balance in there that no one group feels overwhelmed or slighted or cheated. And then in the early days of telehealth, I think the equipment was more of a hurdle than it is now, because economies of scale have made it in such a situation where it's easier to use and there's a lot more interoperability with existing equipment. So I don't know, I just really liked the way that you explained it. And that takeaway, I think, weighs so heavily on whether it's going to be successful or not. So I just appreciate your experience and the way you explained it. So thanks a lot.
When I came here, we had grants and we spent a lot of money buying, computers and screens. And one of the first things school districts said to me was, we don't have a room for the telehealth visit because this big, massive thing. And we've got to the point where if we buy somebody something, it's a laptop with a good camera. It should be portable. And then we have to consider, I think, one of the biggest changes that happened during COVID that patients are never going to go back on is how can they do this from their home,
True.
right?
Mhm.
I
That's
agree
true.
with that 100%.
Yeah.
Yeah, you can be so successful, and the home is a good place for care. It is a good place, and especially, gosh, I cannot say enough about remote patient monitoring.
Mhm.
It is so underused, and you could have such health outcome success through really, really using some of these tools and technologies to catch something before the patient even knows it's gone wrong.
Mhm. Yeah.
Yep, thank you for that. Thanks, Shelley. Who else has a question or a comment or a thought on that? Well, I just wanted to bring up a sort of a case. I met with a federally qualified health center in rural western Missouri earlier this week. I'm pretty sure, yes, it was this week. And they have a goal of having 40% of their visits being virtual. And I wanted to talk about that a minute because, you know, Robert brought up remote patient monitoring, but I like to talk about chronic care management. And one of the tools for chronic care management being remote patient monitoring, which does include a video visit, right, component to that. And so getting, you know, new data in, especially as we think about value-based models. And in Missouri, I can't speak to other states, but in Missouri, we do have through Medicaid, we do have those primary care health homes. And so with that, when you're looking at that model, and then it doesn't matter. I mean, you can have as many visits with that patient as you can. It's not just you do need to visit with them once a month for that to be compliant. But if you're using all the tools available to get all the data in to better manage their care, to then keep them out of the emergency room and into more primary care visits, then we should be able to see a reduction in cost. And so the health center that I was speaking with, I was in a meeting with their CEO and their COO. And what I think that what surprised me was that the chief operating officer knew so much about telehealth, had so many goals, and had a vision for her organization and all of their satellite clinics to be able to transition. And one of the things they said to me was that their healthcare providers within their organization did not like to outsource any pieces of the care to external organizations. So if we were talking about remote patient monitoring, they really wanted the nurse care manager piece of that, the person who is keeping an eye on all the numbers or alerts that are coming in. They wanted that done in-house because they felt like that if they outsourced it, then the patients would not get as good of care. They wouldn't know the specifics about that patient, maybe not know the culture or know the patient. So I just kind of wanted to bring this up and see if anybody has had any similar conversations with entities or within your own organizations thinking through that. So just, I'm going to pause and open it up for comments.
This is Shelley. I've got a quick question on that. If their goal is to have 40% visits being virtual, do you know what their current percentage was? Was that going to be a huge increase for them?
I do kind of know what it was because during the pandemic, things reached, you know, under a federal report that came out in Missouri through Missouri Medicaid, we did reach the 40% threshold.
Okay.
Of 40% of the visits during the height of the pandemic were being done virtually. And so I don't think that they were picking that out of thin air. I do think it is something that has been thought through. And so they were doing it, but things so quickly contracted back.
Right.
From that because they didn't have, they had the approaches during the pandemic that we're only doing this because we can't get patients into the clinic. And so as soon as that was gone, that feeling was gone, then people were just coming back in a clinic. And I've even heard from several different clinics, including where I work, is that, oh, we want all the patients to come back in the office. Yeah, I've kind of heard people say that, and I'm like, why? Why do you want people in your waiting room? Why do you want sick people in your waiting room?
That's true.
I just have to say, so I totally get it as a former CEO wanting to, my staff know my patients, especially in a rural area. So if you could manage care management, and there are ways. One of the things to know is, granted, you may not be big enough, but if there are for-profit companies doing it, there's money to be made, right? So whenever a for-profit company would come to me and say, hey, we want to, the Medicare, having the nursing calls, right? There are for-profit companies that are saying, hey, we'll do those calls for you, and we'll give you, Medicaid pays 60 something bucks, we'll give you 40 of that, right? If there's so first thing is, they're right that if there's a private company that says they'll do it for them, there's money in it, right? Because private companies don't have business models, but they have to be big enough. So for remote patient monitoring, it comes back to, okay, how are you going to define the staff? You cannot add this to the staff you have, because let's assume they're all busy, right? You're a well-run organization. So that means the staff you have are working at capacity. So then how are you going to add capacity? And if they can figure out how to add capacity, and they look at the billing and say it'll pay for that added capacity, I say great. And I may be sacrilege, because I keep saying do it yourself, and not because I don't believe in partnership, but because I do think your local community. The communication is going to hopefully be better from an internal person who's sided with you. So I think there's some real positives. So I don't have an issue with them doing it, but they're going to have to really think through the finances. And I think people often miss that. They want to do it themselves. They think they best serve their patients. I totally agree, but it just may not make financial sense.
Mm-hmm. Thank you for that, Robert. We do have two hands up. Anne, would you like to go first?
Hi, I just want to say real quick, I have a family member with quadriplegia, and sometimes it's easier for the family not to have to pack the person up into a van with a ramp and get them there. I mean, sometimes telehealth would be much easier for the patient and the family.
Thanks for saying that. I actually did just take a call from someone last week who called my organization because they thought we scheduled telehealth visits for the university, and they said, I need to get my daughter in or my niece in who is in a wheelchair. And so I was able to get her to talk to the family medicine clinic and find out if that first visit, or at least a preliminary visit, could be done over video. So thanks for that. Ariel? Or Ariel?
Ariel, it's okay.
Ariel, thanks.
I did have a question about the FQHC you met with and the topic of RPM. So last I knew, RPM is not billable by FQHC. So do they have a way, aside from chronic care management, that they're supporting that? Because we currently have both, but our only way to support RPM is by adding them to the existing chronic care management. We can't do them separately due to billing purposes.
So Ariel, I'm actually going to hand this over to Robert to have him talk about this for a second, but are you in Missouri, or
I'm in Kansas?
You're in Kansas. Okay.
Yep.
I think that will probably help maybe a little bit with Robert's answer.
So yeah, RPM, and we need to look at that by state as well as by Medicaid agency. It is a problem. Unfortunately, so many of the things that we depend on rural health clinics and FQHCs for some reason, CMS, and statutorily, not just CMS, has walled it off from FQHCs and rural health clinics, and this whole distance site thing, which hopefully is now dealt with, and more and more of these things. But yeah, RPM can be an issue for FQHCs to be able to bill for it. That doesn't keep you, and that's a situation without FQHC if they couldn't bill for it, which I'm not going to get into because I don't know the Missouri rules. Then because I'm actually working with someone right now who kind of wants to. You can offer RPM, right? Your patients can have RPM that you don't bill for, and is outside your scope. We can talk about scope. I can talk about FQHCs all day, but but it gets into scope. I just had a very long TA call yesterday related to someone who wanted to provide a service to an FQHC in Missouri. That there's a question about billable, a question about whether it can go in their cost report. And I said, well, they don't have to have you in their scope, right? You can, services can happen to their patients that are not inside their scope, that are not offered by the FQHC. So it really comes down to, if anybody's considering this type of thing, especially in an area like this where there's some rules specifically for FQHCs or rural health clinics that may get in the way, talk to a good attorney, which billing wise, somebody who knows it, but also make sure it's somebody who also knows FQHCs, because this person yesterday had worked with a very large law firm here in Kansas, but they didn't understand FQHCs, and so they were being told they had to give away their services, which you don't, right? You can work with an FQHC, you can provide services. Your local hospital doesn't give away their services just because your patients go there. They have their own. Anyway, sorry, you know me, I go on and on about stuff, but the answer is, Ariel, always happy and can talk with you if there's some questions there with RPM, and I'd be happy. I'd love, actually, because I'm that kind of a person, to look into Kansas's RPM requirements and Kansas Medicaid policy and all of that. Always happy to do it. And of course, we have Rochelle Marting, I can't think, let me say Rachel Matrova, but Rochelle Marting, who is specifically accessible when it comes to billing and what's billable. So all that to say, happy to get into it, because it's an area that I think needs to be pressed, because obviously I'm a fan of RPM.
Yeah.
And Molly, I see that you have a question or a comment maybe related to how I've confused the issue.
Well, I was just going to reiterate, since Ariel is in Kansas as well, Rochelle Marting, as Robert mentioned, is one of our subject matter resources specific to reimbursements and billing and coding, along with the changes that are going to be happening with the end of the PHE. So we actually have our webinar series. The one coming up for April 4th, I think we just landed on our topic, is going to be specific to how to evaluate your billing and reimbursement processes as you plan for the end of PHE. So we're going to actually step by step, go through that process, and evaluation questions you can ask within your organization, your clinic, or your health system. We also do have some things specific to FQHC billing related to the distance site, originating site, and then also, with RPM being a Medicaid reimbursement in the state of Kansas, you're right, the coding and things like that, that's where it gets a little tricky. So if you initially want to reach out to us, I'll drop some things in the chat box for everybody too. And Ariel, if you are not already registered for our education series, you can go ahead and do that. And then we can initiate contact so that we've got your contact information, and then maybe we can move into the next steps in terms of helping you evaluate your current models and see what you can do to get ready for the end of the PHE coming December 2024. I say end is in May, but the flexibilities and things like that will be coming to a harder end in December 2024.
Yeah, I'd really like that. Thank you guys for that feedback. It's been a struggle. We got all the devices and everything actually gifted to us. So, I mean, it's not stopped us from monitoring patients remotely by any means, but really it's one of those things that we have staff applied to it with no resources to pay for it. So, but we're not going to not provide that for our patients as well.
And Ariel, that is definitely a Kansas thing, because I just did some.
Yes, it is.
Because HRSA even put out money for FQHCs at RPM. So
to get the devices, correct.
Yeah, let's talk about this. I'm happy.
Because we invested in a pretty large sum of Welch-Allen scales and blood pressure cuffs. They interface to our EMR. It has a lot of great usability, but again, it's just kind of such a bummer that, hey, here's the funds to get it, but also, by the way, you can't be reimbursed for it.
Well, I don't know Oklahoma, but I've worked in Missouri and Kansas, and I say this a lot. I tell this to Kansas government, which I don't care if they like it or not. It amazes me ways that Kansas Medicaid could save money, whether it's they didn't go big into health homes, and I'm partially responsible. I was in charge of that, and I left the state. But Missouri Medicaid, they find ways to save money, and then they implement it quickly, and Kansas doesn't. And I'll say that. I've said it to KDHE. I've said it to them. I've said it many times to them. In the last month, I've said that to them. It just amazes me how they shoot themselves in the foot. Sorry, I shouldn't be so vocal, but what are they going to do?
It's good. I really feel strongly that if we have successful pilots and successful implementations of different types of programs, it is incumbent upon us to tell people who are in charge of making decisions about reimbursement or funding so that they know, so that they can change policy. So I want to thank everyone for interacting with us today and coming and joining us on this Echo. It's been a lot of fun and very informative, and I'm so happy to see all of most of your faces. And we will see you in 1 month's time on the 18th of April. We're going to have a new program about clinical providers and teams. Okay, thanks everybody.